Chapter 42, Nursing Care of Women with Reproductive System Disorders. Okay, so our learning outcomes, we're going to explain the pathophysiology of each of the disorders of the female reproductive system, describe the etiology, signs, and symptoms of each disorder, identify tests used to diagnose female disorders, and describe current therapeutic management for each disorder. List data to collect when caring for patients with disorders of the female reproductive system. Plan nursing care for female patients with reproductive disorders and explain how you will know if nursing interventions have been effective. Compare different forms of uh, contraceptive and their effectiveness, contraception. Okay, so benign breast disorders. We have cyclic breast discomfort. Okay, we have cyclic breast discomfort, fibrocystic breast disease, and mastitis. Um, so cyclic breast discomfort is when you have breast discomfort that correlates with your cycle. Sometimes you have firm areas of the breast depending on the date of your cycle. Fibrocystic breast disease, it means that they're the cysts that people will take out during mastectomies, but they're benign. Some women have them more than others. And of course, mastitis is an infection of the breast tissue. Breast cancer, the risk factors are age, family history, a high fat diet, high alcohol intake, estrogen treatment, early menarche, late menopause, late or no pregnancies, and no breastfeeding. So breastfeeding actually deters breast cancer. I would say the two highest risk factors, though, that are mostly addressed are age and family history. So if you have a family history, a close family history of breast cancer, you should be getting mammograms at like 35, 30 or 35, I believe it is. Signs and symptoms is lump or thickening of the breast tissue, dimpling, clear or bloody discharge, swelling, tenderness, discoloration. Oftentimes there's no pain. That's the scary part about breast cancer is sometimes if there's pain, that's probably a good sign, is what I've heard in the past. I cannot seem to get very comfortable here. Okay, sorry about that. Um, Prevention. So we want to be careful about our fat intake, alcohol intake, and hormone use. Here's the thing though, contraception is hormone use as well. They don't really talk about that as being part of the hormone replacement therapy that's taken after menopause. I think that is much more um, cohesive to breast cancer than contraception, but it's still hormone use. So breastfeeding is also a good way to help prevent and early identification. There's now a way they can pick up the gene. If they do gene therapy on you, they can find the gene that causes breast cancer and just completely take your breasts off. That happened to two of my family members. My aunt, her mother passed away from breast cancer, and she had both breasts completely taken off and then had implants placed back because she was having to have lumpectomies, biopsies every single year, and it was just really hard on her emotionally. So she decided that was the best thing for her. So your diagnostic test is, of course, your breast self-examination. The clinical breast examination is just the same thing, only a doctor doing it or a nurse practitioner. A mammogram is the best way to detect, and a biopsy is the best way to confirm. But yes, all these are diagnostic tests. Our therapeutic interventions is to, of course, have a lumpectomy and possibly a mastectomy, a partial, simple, or radical. Partial means you're just taking out the lump and surrounding area of the lump. And simple is just the breast tissue itself. Like, for instance, if you have breast cancer of the nipple, then just taking off the breast may be enough. A radical is when they go in and take out not just the breast, but the plate. They'll go into the plate and the lymph nodes all into the axilla of the body. That's considered a radical mastectomy, and it's pretty significant, pretty life changing, pretty painful. It may affect the arm circulation. It will affect the movement of the arm for a long time. They will have to have therapy. Also, there's radiation, chemotherapy, hormonal therapy, and targeted therapies, which um, they have a way of basically using your immune system to attack the cancer cells. Problem is you better have a pretty good immune system to attack them. All right, so this is a mastectomy reconstruction. Um, you know, some women, I mean, it's becoming less and less, but some women were okay with just not having breasts. Like, they survived, that was what they're happy with. Breasts to them were something that caused them a significant amount of pain, not beauty in their eyes, so they just went without. But now insurance is covering breast implants for the purpose of body image awareness and to increase self-esteem and things like that. So it's happening more and more where women opt to have mastectomy reconstruction because it is covered now by insurances. So nursing diagnosis for mastectomy is anxiety, ineffective breathing patterns, risk for ineffective peripheral tissue perfusion. Remember I was telling you about um, all the lymph that's going to be removed is going to decrease peripheral tissue, yeah, perfusion. So, and ineffective coping. You know, a lot of times, I mean, we get kind of weird about our self-image. Um, you know, you're already going to be going through a lot and almost near death going through breast cancer and having to take on chemotherapy and those things, but then to have to recover with scars and with, less of your body than you had before, that's very visible. Um, it's one of the defining things that makes you a woman is breast tissue. Excuse me. So, going that first, I don't know, first time post-op of not having that is going to be pretty significant. Other breast modification surgeries, you have your mammoplasty, breast reduction, mastopexy, augmentation, and reconstruction. That's just basically make them smaller, make them bigger, fix them, put them up. If there's any kind of scarring or issues that need to be helped, they just pretty much make, most of them are um, cosmetic. However, breasts have been, like I said, since they are a defining feature of being female, um, they can also be very um, personal and affect the self-esteem and self-image immensely. So breast reduction is often done due to decreasing back pain and shoulder pain. Some women have very large breasts, and it helps reduce that strain on their shoulders and back. Implants, well, I mean, there's two different types. There's one that goes over the muscle and one that goes under the muscle. Over the muscle, you have the option of having larger breast tissue. larger breast size because skin is much more pliable than muscle. Under the under the muscle, you would have to go with a smaller, but you would also still be able to breastfeed as well. So that's kind of the thing. All right, menstrual flow cycle disorders. There's amenorrhea, which is not having a menstrual cycle. Hypermenorrhea, which is too much. Hypo is too little of a cycle. Menorrhagia means that you have heavy bleeding, and menorrhagia, yeah, that's heavy bleeding as well. Oligomenorrhea means very little menstrual cycle and too many menstrual cycles. So, like I said, it's a bunch of different words saying the same thing. It's just not a regular cycle. But I mean, there's such a range when it comes to a cycle. I mean, it could be 7 to 14 days long, 7 to 10 days, 7 to 14 days long. So it would have to be like somebody told me one time, in order for you to be considered abnormal, you would be having to have a menstrual cycle for 15 days a month and, bleeding like three heavily the entire time. I mean, it would be hard to classify yourself as having a menstrual flow disorder because the range of a menstrual cycle is so different for everybody and it is so customized to the person. Like everybody knows their own cycle and they can recognize when there's something wrong. But does a doctor necessarily think that that is wrong? You know what I'm saying? So you have to diagnose a abnormal menstrual cycle. Of course, you're going to do a pap smear because we're going to rule out any possible indications that there's a different problem under, that is performing as a menstrual cycle, but is not necessarily so. An endometrial biopsy is because we suspect that you might have endometriosis, which is when the inside wall of the uterus is growing on the outside wall. Like it's a different, we have layers of shedding on the outside. The reason why that's such a problem is because the ovary, it sticks to the wall. Remember, the inside of our uterus is designed to have things stick to it. That's why we have embryos. That's why we have these little clusters of cells that stick to it and then embed into the wall and become babies. So we don't want that on the outside of our uterus though, because that means that, things like livers and our ovaries can stick to the sides of our uterine wall, making it torquing our fallopian tubes and making it difficult for eggs to pass through the fallopian tubes. So, I mean, we'll see a better picture of it in a little bit, but that's pretty much, we're trying, if you have a really heavy or abnormal flow, it could be endometriosis. Culture as well. Culture is, I heard one time, so a friend of mine, she has a Hmong culture, and I was telling her that I was concerned because I was having heavy menstrual cycles. I know this is TMI, but she said that in her culture, that whenever your menstrual cycles become really, really heavy, it's because your body is telling you it needs to have another baby. And I'm like, oh no, I'll just take the heavy cycles, you know. But that was kind of part of a culture thing. So acceptance of abnormal cycles can depend on your culture as well. The laparoscopy can also detect disorders and ultrasounds, pregnancy testing, and urine and blood testing as well. Sometimes blood testing, like the only thing we're going to pick up is that your hemoglobin's low. And that's going to confirm that you have a problem. We're losing too much blood. So our therapeutic interventions is a dilation and curettage, which is just a DNC. Sometimes that's if a miscarriage is happening and there's still parts of the miscarriage, they'll do a DNC to ensure that the body stops bleeding and the uterus can contract completely and close. There's also a laser ablation, which Ablation means they basically burn the inside of your uterine wall, keeping you from having a cycle. This is not recommended for women who still want to have children, but it is simpler procedure than a hysterectomy, and that is another intervention. Okay, so dysmenorrhea is a painful menstruation. Diagnostic tests like hormone levels, laparoscopy, biopsies, and cultures can be done. Interventions are NSAIDs, hormone replacement, um, correct the cause. Sometimes they do heating pads, exercise, uh, increase fluids, decrease caffeine. They will tell you your own painful menstruation is your fault. But these are some things that I've been told over the years to try to do. All right, so PMS. PMS, premenstrual syndrome. Okay, yes, it is very real, but is it justifiable cause for homicide? No, no, it's not. Signs and symptoms are water retention, headache, discomfort, change in affect, change in concentration. Um, what you want to limit is alcohol, caffeine, nicotine, salt, and simple sugars. We want to use medications, exercise, stress management. There's people who have premenstrual syndrome probably like 3 or 4 days before they start their menstrual cycle. Usually, what I have conflicted it with is when you're really emotional, like I can pretty much correlate anytime I have been really upset about something, it happened to be PMS, but not like violent or irrational, just upset, you know, things that normally probably wouldn't bother you as much, bother you a little bit more. That's kind of what PMS syndrome is. That and bloating and cramping and just general discomfort. Endometriosis is endometrial tissue outside the uterus, like I've already talked about. Signs and symptoms are pain, swelling, organ damage, scar tissue, and infertility. Interventions are surgical intervention, estrogen reduction, medications, and an oophorectomy. Oophorectomy means you're taking out the ovaries because they keep sticking to the outside wall. That's kind of not what you want to do because most people do want to have children. So yeah, that's probably a last resort. Relaxation exercises and heat to the abdomen or back are helpful. Here's the sites of endometriosis. Think about if it was right here around your uterus and your ovary gets stuck to it, and then this fallopian tube is no longer utilizing gravity. It's doing the opposite. It's utilizing gravity to not um, to keep the egg away from the uterus. It's a bad thing all the way around. They're also at a higher risk for tubal pregnancies and other issues. All right, so menopause is perimenopausal signs and symptoms. You have erratic menses, tissue atrophy, decreased lubrication, hot flashes, night sweats, and mental changes. Your treatment is hormone replacement therapy, which is controversial because of your increased risk of breast cancer. There's dietary phytoestrogens, and then there's calcium, vitamin D, dress in layers, vaginal lubricants, and healthy diet. Miss Sacadeli said she never had to go through menopause. It just passed her up. Some women have really, really strong effects of menopause, and some have hardly any signs. If you're the lucky one, that is. Disorder of the vagina and the vulva is overgrowth of organisms like candidias or yeast infections, bacterial vaginosis, and cytolytic vaginitis and trichomoniosis. Medications for these are basically infections. You have orals and creams and suppositories and douching. Douching on a regular basis, though, is really highly not recommended. It's dangerous to the flora of your tissue and the pH balance. So, we basically, the vagina is a self cleansing area. The vulva, however, is not. You must be cleansing the outside, yes. But inside the vagina, no. Keep that basically as your own body keeps that balance pretty well. If you interfere, you're going to cause more chances for infection. So, toxic shock syndrome is a systemic infection. It's a staph or strep. It's caused by highly absorbent tampons. Basically, if you put anything foreign in you for a great long amount of time, meaning about 8 hours, you're at risk for getting toxic shock syndrome because you're basically locking. Remember, our menstrual cycle is for things to flow out, flow out. It's man-made things that stop the flow, okay? And guess what is a wonderful medium for bacteria is blood or lochia. All right, they love it. So whenever you're stopping things that should be coming out by staying in, you are increasing your risk for your body to absorb that bacteria that is being caused. And that can cause, like, we're talking quickly, shock. The signs and symptoms are high fever, sore throat, headache, dizziness, confusion, redness of the palms and soles, skin rash, blisters, and petechiae. You can die from this. It is very dangerous. Change a tampon at least every 4 hours. Substitute pads, wash your hands, use caution with barrier contraceptives, and report symptoms promptly. I'm kind of worried about um, the cups, the menstrual cups that are coming out because they're designed to stay in for 12 hours. And really, nothing is designed to stay in that area for 12 hours during a menstrual cycle. I just want to put that out there. I know they've probably been tested or whatever. They couldn't be on the market if they hadn't been, but that's pretty alarming to, I mean, just kind of think that one through. If toxic shock syndrome is a risk for something to be in there longer than 4 hours and you're leaving something in there for 12. Mm. Genital organ development disorders. You have agenesis and hypoplasia and imperforated openings. So, organ development, um, okay, imperforated openings means when you're born with your anus closed or your no vaginal opening or the penis opening is closed, the urethra opening is closed. Those are imperforated openings. Displacement disorders are cytoceles. It's when fluid is, I'm sorry, cystocele is when the bladder is coming through the wall, an opening of the wall of the uterus, or it could be, it's usually the uterus though. Rectal seal is when the rectum is coming through the vagina, wall of the vagina. I'm sorry, it's when the bladder is coming through the wall of the vagina, not the uterus. Not the vagina, yes. So, and the uterine position disorders is whenever you have a tilted uterus, it makes it difficult to get pregnant. But there are certain positions that make it a little bit easier. And then, of course, uterine prolapse happens from having children too close together without letting your body heal before having another baby. So, yeah. So a cystocele is when the bladder is coming through the vagina. hmm Rectocele is when the rectum is a bulge coming out. Um, yeah. See how that's the vaginal wall, and then there's a bulge. Yep. All right. So we do ultrasounds, hysterosalpingiographies, CT scans, MRI scans, and sometimes, I mean, if you have a vaginal, just doing a vaginal exam will show you that, there's something coming through the wall. So that's a good indication to go ahead and um, start scheduling a surgery because the only corrective way to do it, okay, there is a pessary, which we don't even utilize anymore. I mean, it's something that they would put in the vagina to hold up the bladder so you can empty the bladder completely. Because just think, if half your bladder is going through your vaginal wall, is it being emptied? No. And what does that increase your chance for? Infection. So these women are not only having their bladder come through their vagina, but on top of that, they're having bladder infections, pretty much chronically. And now we're going to tell them they have to stick something in their vagina in order to empty out their urine. No, we tend to try to get away from pessaries unless they are elderly and can't maybe do a surgery. But surgical correctness is usually the best way to fix prolapsed uterus and or rectoceles or cystoceles. Also, Kegel exercises can help, but if it's already protruding through the wall, probably going to have to do surgery. Um, yeah. So here's uterine positions. There's anteversion, which is, if you notice this is, look at how the uterus, look at this retroversion and then of course retroflexion. So anteversion is kind of the normal way our uterine positions. This right here, think about, why is this important, you ask? I get it. It doesn't seem like it would be. But if you think about pregnancy and how things travel and go through the canal, and, I mean, we're talking liquid and gravity. That's what's making the sperm move as much as it can. And so if we don't, sperm doesn't move well uphill. Does that make sense? So that's kind of one of the reasons why some women have difficulty getting pregnant is because of uterine positions. And of course, your prolapsed uterus, see our normal uterus right here, and then your first degree means it doesn't coming out of the vagina yet, but look at this one is already the second degree, and then of course there's third degree. By the way, this is very painful. A friend of mine said she was brought to her knees going through Walmart. Just it dropped completely out, and she thought she was gonna kill over. So prolapse, you use a pessaria as well. Kegel exercises and surgery, most likely surgery. They can do vaginal hysterectomies, especially if it's already halfway out. It's not as difficult as an operation. And remember, our vagina tissue it's designed to heal quickly. So, if I had a choice between an abdominal hysterectomy or even a laparoscopic hysterectomy and a vaginal, I'm going to take a vaginal one because that area is kind of designed to heal and it would heal fast in comparison. All right, so we have fertility disorders. You have your ovulation, tubal, and uterine, and other problems that can happen. Some women don't ovulate. Tubal issues like their scar tissue from either STDs or other tubal pregnancies. Um, the uterus may not build a wall that can support a fetus. There's lots and lots and lots of reasons why fertility disorders exist. So reproductive life planning, you have your oral contraceptives, your contraceptive implants, um, depot medications, which is your depot shot, right? Your contraceptive rings, your transdermal patches, barrier methods, spermicides, intrauterine devices, natural family planning, and of course your lactational amenorrhea method. Okay, so it seems like the further down we went, the less um, so depending on your situation in life, I guess you could say would be how you would approach your reproductive life planning. Like, you know, some people, these are all pretty much the same. They're hormone, and, driven. They can pretty much, I don't know, depending on what you feel like doing. I mean, I cannot take a pill every day. I will end up pregnant every single day, every single month if you are depending on me to take a pill at the same time every day. That's not going to happen. I had to have the shots. But I didn't have any problems with the shot. A lot of women do have problems with the shot, like weight gain. And I had weight gain, but I don't care about that because it's not still isn't as much as a baby. That was my reasoning. The other thing is that you have to be aware of the risks involved. Like blood pressure cannot be high. It puts you at high risk for blood clots in your legs. So those are some things you need to take into consideration. If you smoke, you know, hormone contraception is probably not for you. The female condom, yeah, great. They're not as effective. They're only about 80% effective as male condoms. The diaphragm, these are all for female contraception. But you would put sperm. Okay, so these were really big in the 90s, 80s and 90s. Um, they're kind of like a rubbery cap. And they used to put, the reason they don't use them anymore is they used to preserve them with talc powder, and talc powder is now associated with cervical cancer. So they don't recommend that anymore. Now you use a lubricant of some sort. But they put spermicide in the inside cup and then place it. But I mean, this is not convenient, nor is it. You can put it on up to 8 hours before intercourse, and it's still supposed to be effective. But you have to leave it on for about 4 hours after intercourse for it to be effective as well. So there's a lot of. It's only about 85% effective. Sterilization is 99.9% effective. A tubal ligation or a vasectomy. This is if you are absolutely done having children. This would be something to consider. Pregnancy termination, there's ethical issues, of course. Therapeutic versus routine. Therapeutic meaning is it to save a life? Reasons, or if the baby isn't going to be, whatever your reasons are. There's ectopic pregnancies, there's prenatal abnormalities, risk factors are pretty high. Lots of cultural implications in pregnancy termination. Of course, we're talking about abortion. It's even illegal in some states now. It's unfortunate because not all abortions are for therapeutic reasons. Often they are medical reasons, and those are not differentiated in the laws very well. So, um, pretty bad stuff. Anyhow, our methods are chemical, which is pill basically, menstrual extraction, which is basically they induce a menstrual cycle. Vacuum aspiration usually has to be done for babies of later or embryos of later dates. And D&C is another way of doing that as well, where they dilate the cervix and basically scrape the inside of the uterine wall. Saline and urea injection and hysterotomy. Post-abortion care, we want to monitor for bleeding, teach and report bleeding signs of infection, abstain from intercourse, and definitely start um, introducing birth control. And we may need to do some grief counseling. So benign growths are like fibroids or polyps or cysts. Fibroids tend to be on the ovaries, but they can be on the uterine wall as well. Polyps, polycystic fibroid or polycystic ovarian disease. That's when you have cysts growing on the ovaries. The issue with that is the cysts block the release of the egg, and that can cause some severe menstrual cycles, severely painful menstrual cycles, and also difficulty with fertilization. Here we go. Endocrine imbalance, you have infertility, obesity, menstrual disturbances, masculinization, because remember, if it's blocking the egg, it's also blocking estrogen, and estrogen keeps us from having um, male, I guess, tendencies like your deep voice and your beard. They think you're gonna, but you know what? This is ridiculous because a lot of women suffer from polycystic ovarian disease. They have nothing that resembles a beard. They have nothing that resembles any of these things. Nothing. They don't have a deep voice. They don't have any. They just have heavy menstrual cycles, and they're not able to get pregnant. And this is whenever they go in, they say, wow, you do, but you don't look like you would. Well, that's because they profiled it. That you're supposed to look like a man if you have polycystic, and that's so not the truth. But other things that can cause that are diabetes, hypertension, coronary artery disease, and endometrial cancer. Therapeutic interventions are oral hypoglycemics, oral contraceptives, so you get to replace the hormone that's not able to be released, anti-androgen agents, gonadotropin releasing hormone agonists, and diet and exercise. So malignant disorders are your vulvar cancer, cervical cancer, endometrial cancer, which is uterine cancer, and of course ovarian cancer. These are very, there's not a lot, unfortunately, they don't have a lot of chemotherapies for women's parts. I know that sounds ridiculous, but it's usually either cut it out or burn it out, but they don't do a lot of chemical. So risk factors for vulvar cancer is sexually transmitted infections like vaginal warts. If those don't get removed, they can turn into cancer. Immune system suppression and smoking. Signs and symptoms are persistent itching, white or red patches, skin ulcers, and wart-like growths. Therapeutic interventions is destruction of cancerous cells, a radical vulvectomy, and skin grafting. That means they either use radiation or they surgically remove your vulva, which would be, wow, difficult. All right, so risk factors for cervical cancer is multiple sexual partners. The number one risk for cervical cancer is the same thing we just get a vaccination from now, right? Which is your, oh my gosh, my brain's not working very well, HPV. So HPV is one of the, like 90% of cervical cancers are from HPV. We get rid of HPV, like everybody gets immunized, you pretty much have cured cervical cancer. If you've had more than 3 pregnancies, you're at higher risk for cervical cancer. Smoking, overweight, long-term use of oral contraceptives, chlamydia, herpes simplex type 2, and of course, if you've had HPV, these are all going to increase your risk for cervical cancer. Signs and symptoms are your serosanguinous discharge. It may be asymptomatic, so you never know. When you're doing a pap smear, that's when they're trying to test you for that. Literally, I've had a cousin who died from cervical cancer. She, um, yeah, she just went in. She had some abnormal menstrual cycles. She went in and did a pap smear. It came out with cervical cancer. 3 weeks later, she passed away. She has 4 children. So, it happened so quickly. By the time we even knew, we were already planning a funeral. It was insane. So interventions is cryotherapy, laser therapy. By the way, she hadn't had a pap smear for 10 years before that. So are pap smears important? Yes. Yes, they are. Surgical excision. hysterectomy, radiation, implant, and chemotherapy. Endometrial cancer, which is your uterine cancer, is risk factors are estrogen excess, estrogen therapy, and obesity. Remember, fat cells produce estrogen, so if you are overweight, you're at a higher increase due to estrogen excess. Signs and symptoms are abnormal bleeding. Our diagnostic testing is ultrasound and endometrial biopsy, and our interventions are hysterectomy, radiation, and chemotherapy. They do have some chemotherapy for uterine, but not too much, guys. I'm telling you. They either cut it out or burn it out, but they rarely use chemotherapy. If they do, it's just after they've already done the cutting and burning. Ovarian cancer, we're going to have low fertility, late menopause, family history of ovarian cancer, and high fat diet. Signs and symptoms are none until late, and our interventions is a oophorectomy, radiation, and chemotherapy. Gynecological surgery, we have a laparoscopy, a coldoscopy, and a hysteroscopy. These are just different types and reasons. All right, so our post-op care for endoscopy surgery is to monitor vital signs, bleeding and temperature, pain, administer analgesics. Remember, they're going to have a lot of gas pain, and gas pain will establish itself in the shoulder neck area and back. So the only way to get rid of that kind of gas pain from endoscopic surgery is to walk. Lots of walking. A hysterectomy, there's a total hysterectomy, which is your uterus. The supracervical hysterectomy, and then there's a radical. You do it through, they can do it through the abdomen, vaginal, laparoscopic, and now robotic. Reason why you would have one is because of menstrual problems, benign tumors, it's prolapsed, or if there's cancer. So nursing diagnosis for hysterectomy is a risk for ineffective tissue perfusion, urinary retention, and risk for constipation. What are risk factors for breast cancer? So age, family history, high fat. So 1, 2, 3, and 4. Hypertension is not a risk factor. What foods should the nurse teach women with premenstrual syndrome to avoid? Uh, let's go with alcohol, caffeine, number 1. What should the nurse teach a patient about preventing toxic shock syndrome? Select all that apply. Change tampons every 4 hours, yes. Substitute pads for tampons, yes. Drink plenty of fluids, yes. Wash hands, but that doesn't necessarily, whatever. Wash hands before and after handling tampons. We're not going to take, I would say 1, 2, and 4. 1, 2, and 4. Yeah. What can the nurse teach women to help prevent displacement disorders? Sleep on the left side, avoid use of laxatives, avoid sitting for prolonged periods, or perform Kegel exercises. I would say number 4 is your best answer. Which virus is associated with cervical cancer? And remember, we talked about HPV. It's that's the answer.